Documenting the absence of brainstem function is essential for establishing the diagnosis of brain death. In a brainstem dead patient, the cranial nerve reflexes are tested and the absence of brainstem function is documented by conducting several tests like the absence of pupillary reflex in response to light, the absence of corneal reflex, absence of vestibulo-ocular reflex, absence of cranial nerve response to pain, and absence of gag and cough reflexes along with the doll's eye phenomenon. We will now demonstrate each one of these. To check the absence of pupillary response to light, a bright pen torch light should be shown into each eye in a darkened room. The pupils may not necessarily be fixed and dilated in brainstem dead patients. However, there should be no pupillary response to light. It's normal to expect grimacing of the face to painful stimulation. However, this is absent in brainstem death situation. A firm supraorbital pressure should be used to check this cranial reflex. We will now check for the doll's eye phenomenon. To do this test, the doctor holds the patient's head between his hands and moves the head from side to side through 180 degrees. He should hold the head to one side for 3 to 4 seconds and look at the simultaneous eye movement to that side. A similar movement is done to the opposite side and the eye movement is observed. If the cerebral hemispheres are damaged but the brainstem is still alive, there will be an obvious deviation of the eyes to the opposite side for a second or two, followed by a release phenomenon when the eyes will get realigned to the side of the head. We are now going to check for the corneal reflex. What needs to be done is taking a moist cotton tipped swab and applying a firm pressure to the cornea, of course without damaging it. The patient is observed for involuntary blinking of the eyelids. Let's now perform the vestibulo-ocular reflex, also commonly referred to as the cold caloric test. This test involves instilling 20 ml of ice cold water into the external auditory canal and looking at the eyeball movements of either eye for about a minute. No eyeball movement indicates an absence of the reflex. To check the gag reflex, a cotton tipped swab or a spatula or a Yonkar could be used to stimulate the posterior pharynx to look for the response. We will now check for the cough reflex, and this is going to require a temporary disconnection from the ventilator. The cough reflex is tested by using the bronchial suctioning. Either a closed suction or the open suction method may be used when a patient is having an endotracheal tube. For this test, the patient is disconnected from the ventilator for 10 minutes. However, to avoid hypoxia to vital organs, 100% oxygen is given for 5 minutes before disconnection from the ventilator. Even during the test period, 100% oxygen is given through a tracheal catheter. In the patient who is brain dead, the carbon dioxide tension increases at a rate of 2 millimeters of mercury per minute during the apnea testing. If the initial carbon dioxide tension before the testing is about 40 millimeters of mercury, then the arterial carbon dioxide tension after about 10 minutes is likely to be 60 millimeters of mercury. This test is often considered as the ultimate test to establish brainstem death. The spontaneous respiratory response fails to occur even in the presence of stimulatory drive from increased carbon dioxide. Declaring brainstem death is, if anything, a very sensitive issue that I think every single doctor needs to be cautious, because families still have a significant denial on accepting the concept of brainstem death, and that puts the extra burden on us as clinicians to be doubly sure that all the right process has been followed before we actually declare that somebody is brainstem dead, making sure that there are no abnormalities with the electrolytes, making sure that the temperature is normal, making sure that there is no narcotic medication or sedation on board, are all steps that should be included in our protocol and an algorithmic approach. Therefore, there is no flaw in any of the steps followed while declaring brainstem death. Now, despite all this, we still have our challenges while we are going through this process. Number one, this is something that we need to do on a timely basis. I mean, just like we provide care in the ICU on a 24-hour, 7 days a week basis, similarly, clinicians need to be available to declare brainstem death at any time of the day. And it is not always easy to get certified physicians who can declare brain death on time when required. And this is something where the government and all of us are taking additional steps to empanel more physicians who are credentialed to certify brain death. Declaration of brainstem death is not an end. It's the beginning of a new life. It's the beginning of probably several lives that this donor could potentially create or give to others. What is important is for the clinicians to understand that the moment we suspect, diagnose and certify brainstem death, our focus should change and we need to ensure that the organs are appropriately preserved and that there is no lack of perfusion or damage to the organs that could potentially save several other lives. So, it is important at this stage that a team of professionals involving the critical care physicians, the primary physicians, and also the organ coordinators, organ transplant coordinators and the team get involved in creating a protocol and strictly adhering to the protocol and making sure that the organs are appropriately perfused. This might mean placing central lines, arterial lines when appropriate if it is not already there, making sure that appropriate amounts of vasopressors, inotropes are given to maintain appropriate perfusion, giving triple hormone therapy using thyroxine, using steroids to appropriately ensure that the organs are appropriately perfused. And this is a key factor in maintaining the brainstem death organ donor. The next most important thing when we are certifying brainstem death is the fact that it has to be done twice, and each physician should make sure that he or she repeats the entire process again rather than just relying on the previous clinician's findings. Now, despite following all of these steps, there may be certain other clinical conditions that are limiting us from proceeding with the testing, and the most important thing here is hemodynamic instability. If the patient remains hemodynamically unstable, then it would be impractical to do an apnea test, and these are all real life difficulties that we have to encounter, but it is important to ensure that all steps are followed appropriately before we define and declare somebody as brain dead.